Good evening, ladies and gentlemen, respected chairpersons. So you must all be very fatigued, but this is one of the obligations that we'll have to go through. And thanks, Rituparno, for introducing the subject of worsening heart failure. And now I'm going to answer the questions. Do we have any answer to the menace? And I'll have to refer to the Victoria trial, and I'll try to make it a case-based presentation. These are the disclaimers. So, since this is still a Western molecule yet to be introduced in this country, so we'll refer to these two gentlemen and lady, Andrew and Betty, who are both examples of worsening heart failure. Andrew is 72 years old, symptomatic HFrEF, 2 previous worsening heart failure events, diagnosed with HFrEF 2 years ago, first heart failure hospitalization 6 months ago, second recently, optimized on background therapy, has AF, CAD and prior MI. Betty is 59 years old, symptomatic HFrEF with 2 previous worsening events. Diagnosis of HFrEF not more than 8 months back, second heart failure hospitalization only 3 months back, optimized background therapy and has CKD. So Andrew was stabilized with IV diuretics inpatient just prior to discharge, and Betty was managed on OPD basis with side effects resulting from up-titration of GDMT. So this worsening heart failure event not only takes place in IPD settings necessarily. Patients may not be hospitalized. They may present to the OPD as well. Now, what is worsening heart failure event? So, anyone needing an IV diuretic, be it in a hospital setting or emergency department or OPD setting, is worsening heart failure event. And the risk is quite high. 1 in 6 patients suffer a worsening heart failure event within 18 months of HFrEF diagnosis. And with 1 in 3 heart failure patients will experience a worsening heart failure event in 1 year. So that's quite high, and the main problem is that it can happen any time. So very early after the diagnosis of HFrEF, it can take place, and needless to say, it can always occur much more frequently in advanced heart failure. So look at the trials. Rituparno has referred to these trials: Paradigm heart failure, DAPA heart failure, and Emperor reduced. We are all well versed with these trials, but the important thing to be focused on that the fact that Victoria involved a much sicker population of patients. So the eGFR was lower, more than 15. Recent heart failure, by definition, patients with heart failure hospitalization within 6 months or IV diuretic requirement within 3 months were included. Median NT-proBNP was much higher compared to these trials. Heart failure hospitalization in less than 6 months in 84% patients. IV diuretic use was not a mentioned criteria in any of these trials, but it was there in 16% of patients in Victoria. More patients in NYHA class 3 and 4 in Victoria, 41%. 53% had eGFR less than 60, and primary endpoint event rate in the control arm was the highest, 37.8 events per 100 patient years. So needless to say that these patients this particular trial had a much sicker population, and there was 100% focus on worsening heart failure patients. So we have symptomatic chronic heart failure, NYHA class 2 to 4, LVEF, and unavailable heart failure therapies enrolled after a worsening heart failure event in the Victoria trial. So 67% had heart failure hospitalization within less than 3 months, 17% between 3 to 6 months, and 16% needed IV diuretics within less than 3 months, and all of them had elevated natriuretic peptides. So just because we are not sure about the hypotensive potential of this new molecule, so patients who had clinical stability with SBP more than 100 millimeters of IV treatments for at least 24 hours were included in the trial, but there was no run-in period. So, and needless to say, patients were getting state-of-the-art treatment. A very high percentage of patients were on beta blockers, ACE inhibitors, ARBs, and MRAs. ARNI, as per the global standard, 14% people were receiving, and patients on triple therapy was also quite high, 60%. ICD, almost 1/3 had ICD, and biventricular pacemakers in again another 15%. And of all the patients, as I mentioned the percentages, almost 84% of patients had a previous heart failure hospitalization within last 6 months, and 16% were on required IV diuretics within the previous 3 months. So a very high-risk population, needless to say again. But despite that, there was a significant improvement in the outcome, composite outcome of first heart failure hospitalization or CV death. And look at the important parameter of absolute risk reduction in terms of events per 100 patient years, 4.2. And look at the number needed to treat was quite low, 24. So there lies the success of this trial. And if you look at the various individual parameters, the composite endpoint, ARR was 4.2, as I just mentioned. It was driven mainly by heart failure hospitalization reduction, ARR of 3.2. Total heart failure hospitalization, again an impressive ARR reduction, 4.1. Composite of heart failure hospitalization and all-cause mortality, 4.2 again. But there was no basic improvement in all-cause mortality. And the important fact is that this benefit cut across all the subgroups. So this, irrespective of patient was on ARNI or no ARNI, there was benefit. EGFR less than 30 or more than 60, there was benefit. Irrespective of the subgroups of heart failure hospitalization less than 6 months or IV diuretics less than 3 months, there was benefit. And the various quartiles of NT-proBNP benefited, but the point to be noted is that those who had an NT-proBNP more than 5,000 actually did not benefit. There was a subgroup analysis again. Up to NT-proBNP of 8,000 or so, there was some benefit. The major benefit was with NT-proBNP up to 4,000. Those with a higher NT-proBNP should actually be stabilized little more with IV diuretics before they are put on this drug, vericiguat. So vericiguat has a very favorable safety profile. You can see no difference with placebo in terms of adverse events or serious adverse events. There was no difference in symptomatic hypotension or syncope. And very importantly, 90% of patients achieved the target dose of 10 milligram of vericiguat after 12 months of initiation of therapy. So the answer is simple. What does Andrew or Betty need? So they are already on the guideline-directed medical therapy. They are both high risk. So probably vericiguat is the drug that is well suited for both of them. And important fact is that irrespective of the concomitant use of ARNI, there is still benefit in patients like Andrew and Betty on vericiguat. And as you know from our actual clinical experience, many patients either cannot tolerate ARNI because of symptomatic hypotension, or there is some baseline CKD or hyperkalemia. So these are the ideal kind of patients who cannot tolerate ARNI. They can be simply put on vericiguat, and still we can prevent further worsening of heart failure. And as I said, irrespective of the various EGFR profiles, there was uniform benefit of vericiguat compared to placebo. And this benefit was with regard to the composite of heart failure hospitalization or heart failure hospitalization or all-cause mortality. And even for CV mortality, there was, you can see if you do the subgroup analysis, there was no CV mortality benefit with the EGFR of more than 60. But those who had a EGFR of less than 60, there was even benefit in terms of CV mortality. There was no dyselectrolytemia in terms of, sodium and potassium levels. There was no difference from with regard to placebo. So it is a perfectly safe drug as far as dyselectrolytemia is concerned. So again, this is a major benefit vis-a-vis the RAS blockers and MRAs. There was no hypotension at all. Initially, there was just a 1 to 2 millimeter blood pressure reduction with vericiguat, but after all, it was as safe as placebo. And absence of clinically relevant BP reduction with vericiguat even in vulnerable patients. And who are these? Those who are elderly, those who have low baseline systolic blood pressure, and those who are receiving concurrent ARNI. Even in those patients, vericiguat did not produce any symptomatic hypotension. So these are the three subgroups I mentioned. So vericiguat may be suitable for vulnerable patients due to its favorable safety profile, those who are at risk of hypertension, those with pre-existing renal impairment up to a eGFR of 15, and patients who are at risk of developing hyperkalemia. So in all these very high-risk subgroups, vericiguat is a very acceptable drug. So which is the dosage you should start? As in the Victoria trial, we should start with 2.5 milligram once daily for first 2 weeks, build it up to 5 milligram over next 2 weeks, and ultimately reach the target dose of 10 milligram. And as I said, 90% of patients could reach the target dose in Victoria trial. So while starting vericiguat, you remember to make the patients off IV diuretics. They should have a stable blood pressure of at least more than 100 as per the Victoria trial, but probably I have a gut feeling that probably we should be able to use this drug even with a blood pressure systolic of 90 millimeters of mercury. If the NT-proBNP check is not mandatory, but if you happen to check it, if it is more than 4,000, just use IV diuretics for 2 or 3 days more, bring down the NT-proBNP, and then off IV diuretics start vericiguat. And the number needed to treat, I said, was very impressive. It was only second to the emphasis trial with eplerenone and the emperor-reduced trial. Both had 19 NNT, and it was only close third with an NNT of 24, much better than Merit HF and DAPA heart failure even, and of course, needless to say, another upcoming therapy, omecamtiv, which had an NNT of 48. So in patients with recent worsening heart failure event, vericiguat reduced heart failure hospitalization or CV death with an ARR of 4.2%. And as I said, the NNT was very impressive, even in this very, very sick population. So vericiguat is recommended for the comprehensive medical treatment of patients with worsening heart failure on top of the foundational therapies of HEPREF, that is the 4 foundational therapies, ACE inhibitors or ARNI, beta blockers, MRAs, and SGLT2. If you apprehend worsening heart failure, as Rituparna said, how to preempt it, or patient has already suffered an episode of worsening heart failure, vericiguat, as per the Victoria trial, is the drug of choice. And in synchrony with this, the major guideline-making bodies of the world, the ACC-AHA, Heart Failure Society of America, in 2022 guidelines has given a 2B recommendation to vericiguat, and ESC 2021 again has given a 2B recommendation to vericiguat for this subset of patients who are at high risk of worsening heart failure. And the Canadian guidelines have given it a conditional approval, and so it is almost accepted in all parts of the Western world, and we are awaiting the launch of this molecule very soon in our country, and we hope that we will be able to help this group of very sick patients. So we are really targeting a new mechanism of action, the nitric oxide soluble guanidate cyclase and cyclic GMP pathway, which we haven't targeted so far in heart failure patients. We have done it in pulmonary hypertension with vericiguat, but vericiguat is a different molecule, and it has shown very impressive results in Victoria trial in terms of ARR reduction of 4.2% and NNT of only 24, and it has a very favorable safety profile, as I mentioned. So even in patients with a eGFR up to 15 ml per minute, we can use this molecule. So thank you very much for your patient hearing. And now I think the results of the quiz will be out. But before that, if you have any questions, a very short.
Just a comment. I think we don't know how does it work. It is more of theoretical. I was just checking the website, and it's very, very costly in dollars. It's more than 600.
No, they have promised it will not be costlier than ARNI. So,
okay.
we know that ARNI is going to go off patent in January. That's what I have heard.
So, yeah,
so once the ARNI cost comes down, probably in that very sick group of patients, we should be able to use it because we already have at least dapagliflozin off patent. We will be having ARNI off patent, so the total cost of the foundational therapies will come down. So probably we will be able to add this fifth drug in those very sick group of patients.
Yeah, so this is a wonderful, wonderful lecture on that.
We have learned for primary pulmonary hypertension, for this NO level is increasing through the guanylyl cyclinase level is by increased. So same pathway, what I am thinking for that, whether sudden hypotension,
No.
number two, anemia, these two are the concern. Yeah.
Yes, your apprehension is very right. So that's why the trialists actually made the cutoff of systolic blood pressure 100 initially, but they were pleasantly surprised that there was not much of blood pressure reduction with this molecule. Initially, there was just 1 to 2 millimeter blood pressure drop, but then again that stabilized with the continuation of therapy.
Second, only for the HRAF
1 to
below,
2 millimeters, not more than that.
and below 40 only it can be used.
Below?
HF,
Ejection fraction.
Yeah.
Yeah, these were the selection criteria was EF less than 45%.
45, yes.
We have one more question and then we'll wrap it up. It's already very late.
Thank you very much, Dr. Kumar, for bringing out this information to us. I have a small query to know. We have many patients who are having congestive heart failure but stable with our present treatment on OPD basis, but we want to improve their quality of life a little bit. They are on optimal management. Can we add this molecule, can we look forward to this molecule to improve the quality of life a bit in a patient of heart failure with low ejection fraction?
You are meaning a data in the line of KCCQ score and other things. But because this was a very sick group of patients, so main target was reducing further heart failure hospitalizations per se and improving CV mortality. So I am not sure whether a quality of life was studied in the Victoria trial. I have to look up the data little more. But as you said, if you want to try this out in patients who are already on the first four line drugs, and you want to improve their quality of life or reduce risk of heart failure hospitalization, in terms of reduction of heart failure hospitalization, it is well documented. You can definitely try this. As far as improvement of quality is concerned, really we'll have to use the drug and find out whether there is further improvement in the quality of drug.
Thank you so much.
Right.
We will have a lot of questions once we start using it. So till we don't have the real data and the real clinical skills when we have used it. I think we'll talk it in the next year probably. I think the session was wonderful. It was amazing. It's a big chapter and huge chapter about heart failure. And I'm sure we have a lot of questions unanswered, and we probably will be doing it maybe tomorrow. And I think we can close the session, and I think I will hand over the mic because I think the announcement has to be done about the banquet.